Good morning, everyone, and thank you for joining us this morning for Winship Grand Rounds. As a reminder, if you're a Winship or Emory University or healthcare employee and you'd like to receive CME credit, the login information can be found in the chat feature at the bottom of your screen. If you have any issues with the webinar on CME login, please send Fofana Kadiatu an email or drop a note via the chat feature. This morning, we're very excited to have Dr. Dan Zandberg, who's joining us virtually. Dr. Zandberg is a medical oncologist and associate professor of medicine at the UPMC Hillman Cancer Center in Pittsburgh. He completed his medical degree at Jefferson Medical College, internal medicine residency at George Washington University Medical Center. He then completed his hematology oncology fellowship at the University of Maryland Comprehensive Cancer Center. Currently at UPMC, he's the director of clinical affairs and head, neck, and thyroid cancer disease sections. He co-leads the UPMC Hillman Head and Neck Cancer Program. I know Dan personally, and he's been very active in clinical and translational research with a focus on advanced head, neck cancer and cutaneous squamous cell cancers. He has had significant presence within NCTN through development of phase 2 and phase 3 trials. He chairs ECOG 3191, which is a trial focused on locally recurrent head and neck disease, as well as an alliance trial focused on recurrent skin squamous cell carcinoma. His recent awards include the NCI Cancer Clinical Investigator Team Leadership Award and the Alliance for Clinical Trials in Oncology Scholar Award. Dan, it's really great to have you, even though virtually, and we all look forward to your talk.
Thanks, Nabil, and thanks for inviting me to give this talk today. Today, we're going to talk about immunotherapy for recurrent metastatic head and neck cancer. These are my disclosures. And the goals of the talk will be multiple. We're going to talk about how immunotherapy is part of our standard of care in the recurrent metastatic setting. And then where are our needs? Where do we need to go? Where are the future directions? And then I'll end by briefly talking about some stuff that we're doing here at Hillman towards those goals. So as a medical oncologist, really I liken taking care of head and neck cancer to a double-edged sword. On the one side, we are lucky that we catch most of our patients at a stage where we're shooting for definitive therapy. On the flip side, when our patients recur and or develop metastatic disease, they face tremendous morbidity and also high mortality. And we really lag behind other tumor types like breast, colon, subsets of lung in terms of our outcomes with systemic therapy. To kind of summarize the field in 2 slides, we'll start with anatomy. Of course, as this group knows, head and neck cancer starts within the mucosal lining of the structures within the head and neck. Most common histology is squamous cell carcinoma. And the most common sites we see in the US are the oral cavity, the oropharynx, primarily the base of tongue and tonsils, the larynx, as well as the hypopharynx. The other sites, paranasal sinuses, salivary glands, are more rare, and nasopharynx, the bulk of those patients are in Asia. We do see some in the United States. And so today, when we're talking about immunotherapy and recurrent metastatic head and neck cancer, we're focusing on the common sites, which are lumped together for study, and that is oral cavity, oropharynx, larynx, and hypopharynx. So where is the field today? Basically, we have 2 different diseases. We have HPV positive oropharyngeal cancer, where we know there's a much better prognosis in the curative intent setting. And then we have HPV negative oropharyngeal squamous cell carcinoma in our other sites where there's a great need for improvement. And that has led in the locally advanced setting where we're shooting for cure to good risk HPV positive patients being de-escalated in trials, intermediate risk HPV positive patients and HPV negative patients being escalated to try to improve outcomes in the locally advanced setting. In the recurrent metastatic setting, which of course is our focus today, all patients need improvement in outcomes. HPV positive oropharyngeal cancer patients do have a slightly better prognosis in the recurrent metastatic palliative setting, but their care is still palliative. And so there's a great need for improvement for all of these patients when it comes to the recurrent metastatic setting. So briefly, how do we approach a patient that recurs? If you have a local regional recurrence, we first ask the question, do you have a salvage resection option? If you don't, do you have a reirradiation option? And if you don't have a local option for your local regional recurrence, then you're on to systemic therapy. And it's not quite as simple as just going down the line here. Obviously, morbidity and biology is taken into factor when it comes to resection or reirradiation. And if you do have distant disease, plus minus local regional recurrence, then you're on to systemic therapy. So as we transition to focus on immunotherapy and recurrent metastatic setting, what do we know about the tumor immune microenvironment in head and neck? Well, compared to other solid tumors, it can be an immune infiltrated tumor. You see here HPV negative head and neck cancer, a little higher up, HPV positive oropharyngeal cancer. But it can be immune infiltrated, but immune infiltrated with immune suppressor cells. You can see that it's one of the highest tumor types for immune or Treg infiltration, and also a low, or I should say high Treg CD8 infiltration ratio. So it can be immune infiltrated, but if it is, oftentimes it's infiltrated with suppressing cells relative to the immune response. This is data shown on top here, looking at a chemokine signature, characterizing patients as T cell inflamed, high, low, and intermediate. And as expected in head and neck cancer, there's a spectrum, about 30% TCIP high, about 30% TCIP low, and about 30%, 35% in the middle at intermediate risk, or excuse me, intermediate status. When we look at HPV positive oropharyngeal versus HPV negative, you see that HPV positive patients have a higher proportion of T cell inflamed high compared to HPV negative, but amongst both groups, there's a distribution of T cell inflamed phenotype. HPV positive oropharyngeal cancer mostly has been found to have a higher CD8 infiltration, questionable differences in Tregs compared to HPV negative, higher M1 macrophages, lower MDSCs, generally speaking, found to have a tumor-immune microenvironment that is more inflamed. Other things that are associated with either increased immune infiltration and activation include mesenchymal subtype, certain mutations, for example, HRAS, some increase in pathways, for example, JAK-STAT, and things associated with decreased or increased molecular smoking signature, increased hypoxia, which we'll talk about, P53 mutation. So different things correlate with either an increased immune infiltration and activation status or decreased. But I think the point is that certainly there's a spectrum amongst our amongst our head and neck patients. Now, the important critical work that I highlighted, and the bulk of our work on the tumor immune microenvironment, is actually in the locally advanced setting, because tissue, and especially large volume of tissue, is just more readily available. This is a unique study by Waterman and colleagues where they looked from primary head and neck cancer presentation to recurrent, since most of our patients present at a stage where we're shooting for cure and then they can recur, and looked and said, what are the differences in the tumor immune microenvironment? And so when you recur, there can be a decrease in B cells, CD8 T cells, NK cells, a decrease in CD8 Treg ratio. And they also looked at our bread and butter treatment, which is chemoradiation. And for patients that get chemoradiation, there was a significant decrease in B cells, an increase in macrophages and neutrophils, and downregulation of genes associated with cytokines and B cell response. And this is interesting, because basically when we treat these patients, at least in the peripheral blood, we see lymphopenia that basically persists for the rest of their course. The point of which is that the recurrent phenotype is likely even more suppressed than the patients in locally advanced. And so for us, when it came to immunotherapy, as is tradition in medical oncology, we start in the most refractory setting. And for us, this was platinum failure. That is those that have recurrent or metastatic disease that fail platinum-based chemotherapy, and then they're on to their next therapeutic. And this was in 2016 with Checkmate 141. which randomized to Nivolumab versus standard of care dealer's choice, Cetuximab, methotrexate, or taxane. And Nivolumab significantly improved overall survival compared to standard therapy with a response rate of 13%, no difference in progression-free survival. And this was no small feat. This was the first agent to significantly improve overall survival compared to another agent, and that other agents that have been compared in the past have been placebo, the first agent to improve overall survival in this platinum failure setting. So it represented a big win for us in head and neck cancer. Subsequently, in 2019, we had our frontline trial, which is Keynote 048. And this was a very elegantly designed trial. These were for patients that were systemic therapy naive, and they were randomized to Pembrolizumab monotherapy, Pembrolizumab plus chemotherapy, where that chemotherapy was platinum and 5-FU, or at that time, our current standard of care, or excuse me, our standard of care at that time, which was platinum, 5-FU, and Cetuximab, the extreme regimen, was powered for overall survival, comparing Pembro monotherapy to extreme and comparing chemo plus Pembro to extreme for 3 categories: those with a combined positive score greater than equal to 1, greater than equal to 20, as well as the total population. So 3 comparisons there. And so this shows the winner's box. Basically, Pembrolizumab significantly improved overall survival for a CPS greater than equal to 1 score, PD-L1 score, a CPS greater than equal to 20. It did not improve overall survival for the total population. And chemo plus Pembro significantly improved overall survival compared to extreme for all 3 categories: total population, CPS greater than equal to 1, and CPS greater than equal to 20. This shows you some of the curves. As is with other solid tumors, the median duration of response with Pembro monotherapy was 20 months, driving that difference in overall survival, but no PFS difference. And so where we are in terms of our standard of care use of immunotherapy in the recurrent metastatic systemic setting, for front, we have our now indication based on 048 since 2019, where for the total population, or if you don't check PD-L1, or if you're PD-L1 negative, platinum 5-FU Pembro is your choice. If you are PD-L1 CPS greater than equal to 1, you have the option of Pembrolizumab monotherapy or platinum 5-FU plus Pembrolizumab. Now, the platinum failure indication has been superseded by the frontline indication. However, one definition of platinum failure used in those studies was the failure of platinum-based chemoradiation within 6 months for locally advanced disease. And so that indication still holds. That is, those patients that fail within 6 months of platinum-based chemoradiation are still applicable to the platinum failure indication, where both Nivo and Pembro are approved, and they're approved regardless of PD-L1 status. So what are our needs based on Keynote 048? Well, if we dive in deeper with an exploratory subgroup analysis by PD-L1 expression, we see the following. So for patients enrolled in Keynote 048, 85% will PD-L1 expressors with a CPS score greater than equal to 1. Amongst those that were PD-L1 expressors, nearly half, 44%, had a CPS greater than equal to 20. So it brings up the question as to whether the CPS greater than equal to 20 patient population accounts for the benefit of Pembro in the CPS greater than equal to 1. So this is exploratory subgroup analysis. As expected, CPS less than 1. Response rate with Pembro is only 2%. Low efficacy there. Again, total population, there is no indication for Pembro monotherapy. But what's interesting is when you look at the CPS 1 through 19, you see here the hazard ratio goes up to 0.86. Confidence interval crosses 1, and the overall survival is pretty similar. CPS greater than equal to 1, you see the hazard ratio down to 0.58. And this is exploratory, but suggests that perhaps we need more than Pembrolizumab monotherapy for those low PD-L1 expressors, CPS 1 through 19. So the other thing for us to interrogate is our chemotherapy plus Pembrolizumab. How well are we doing here? Well, what this shows you are the response rate for chemo plus Pembro, Pembro monotherapy, and then extreme, again, that control arm. And what you can see is, although not formally compared to each other, chemo plus Pembro had approximately an 18% increase in response rate. However, the median duration of response of chemo plus Pembro and PD-L1 expressors was nearly fourfold lower compared to Pembro monotherapy. And this is shown in the curves here relative to the duration of response with chemo plus versus Pembro monotherapy. And I won't dive too deep in this other than to say that this is a big interest of mine. I think what it says to us is that we have to figure out a better sequence of chemo and Pembro for us, for head and neck cancer patients, because despite a higher response rate, it's a fourfold lower duration of response, meaning our dosing is likely taking away from that duration of efficacy that we expect with anti-PD-1. I won't go into that further, but notable to highlight and a story for another day. So what are our future directions? Well, frontline setting, we need to improve beyond Pembro monotherapy and improve on chemo plus IO. And we're going to talk about the first one mostly today. And that has come in the form of combination immunotherapy or targeted therapy plus anti-PD-1. There's a need for improvement in the IO failure setting, plus minus platinum failure. And of course, biomarkers, as well as, and I'll talk about the end, can we integrate immunotherapy earlier on in the recurrent metastatic setting? So good news for our patients is that there is an explosion of trials and has been for a while in head and neck cancer, as shown here, which is great for our patients and great for the field. So what else has been evaluated since Keynote 048? Well, this is Checkmate 651, which looked at Nivo-Ipi versus the extreme regimen, frontline trial, same patient population as 048. And what it showed is that for the primary endpoint, all patients in the trial, there was no difference between Nivo-Ipi versus extreme, no significant difference in overall survival. Now, it didn't meet statistical significance. It lost power. It wasn't the primary endpoint. But importantly, it showed that, look, Nivo plus Ipi in PD-L1 CPS greater than or equal to 20 patients did show a split of the curves, 41% versus 33% at 2 years, had an impressive 36% response rate with 12% CRs. So at least in that PD-L1 expressors, Ipi-Nivo seemed to perform more impressively. However, and it's much easier, of course, to play Monday morning quarterback, that was not the primary endpoint, but interesting nonetheless. And so unfortunately, we've had some negative phase 3 trials already. Checkmate 651, I just highlighted, Tremelimumab plus Durva, anti-CPA4 Tremelimumab, anti-PD-1 Durva, similar trial, frontline Kestrel, that was negative. And ICOS plus Pembrolizumab was in a phase 2/3 trial, and there it didn't pass muster in the phase 2, so it didn't move on to the phase 3. So we've had, unfortunately, some negative attempts since Keynote 048 to try to continue to improve outcomes for this patient population. So when it comes to combination with immunotherapy, what are some combinations that are starting to make progress? One of that is with anti-B7H3 targeting. This is Enoblituzumab plus Pembrolizumab. This was patients that were IO naive. Most of them were platinum failure just by nature of when the trial went on. And you can see a response rate of 33%. You compare that to 048, around 20%, platinum failure around 15%. So a decent looking response rate in the IO naive setting, not much activity in the IO failure setting, and Enoblituzumab plus anti-PD-1 or PD-1 LAG3 is currently in a phase 2 that's ongoing in head and neck cancer. When it comes to vaccine, we have the HPV Vaccine ISA101, which is a long peptide vaccine with peptides for both E6 and E7. This is preliminary data. This was a single arm trial with Nivo, and you can see also a higher response rate, 33%. Of course, these were all patients that were HPV positive, the bulk of which were oropharyngeal cancer patients. These were refractory patients. And so this vaccine is also being tested in a randomized phase 2 trial, plus Cemiplimab versus Cemiplimab alone in HPV positive oropharyngeal cancer patients. What about intratumoral injection? This also is a little bit earlier on for us, but this was preliminary data using ADUS-100, a STING agonist, intratumorally injected plus Pembro in frontline patients. And this was preliminary data presented at ESMO showing 8 patients. And as you can see, most achieved either stable disease or response. Looking at whether it was the injected lesion in black or non-injected, one patient had significant response in the non-injected lesion, or actually a couple, I should say, in addition to the injected. And for some patients, this was more durable. Unfortunately, the company Aduro got bought by another company who was not interested in oncology. So this trial actually closed down. Its goal was 34 total patients. I had one patient on the trial that did have a near CR at the injected lesion and was on therapy for a little over a year before progressing overall. And there are other ongoing trials looking at intratumoral injection in head and neck, including TLR9 agonists, oncolytic viruses as well. And I think this is interesting in head and neck, that is an intratumoral injection. A lot of our patients face morbidity from local regional disease. So if you did have an injectable agent that at least could give you regression at the injected lesions, and of course we would hope it would work or add or drive synergy in the non-injected lesions too, but there could be the potential for a big benefit in terms of morbidity. And of course it would have to prove itself in terms of overall survival as well. And I think the challenge to the field is how do we scale this up? We think about our head and neck patients as having easily injected lesions, but the reality is in the recurrent metastatic setting, they are harder to find because a lot of times what defines a patient as local regional recurrence that doesn't have a local option can be significant arterial involvement and therefore excludes them from intratumoral injection. So I think the question to us as a field as to if we get good preliminary efficacy, how can we scale this up into a registrational trial to make this standard of care or to lead potentially to a change in standard of care? Another targeted therapy that's shown good promise has been Cetuximab. So Cetuximab is a monoclonal antibody, IgG1, that's targeted against EGFR. As an IgG1 monoclonal antibody, data led by Dr. Ferris here has shown that it can induce ADCC, and that ADCC can lead to crosstalk between NK cells and dendritic cells and activate adaptive immunity with CD8s targeting EGFR. And with that backdrop or that rationale, it was combined with anti-PD-1 in 2 studies, one by Dr. Sacco, another one by Dr. Chung. And the Dr. Sacco study looked at all IO naive patients with a response rate of 45%. And the Chung study looked at both naive as well as IO failure patients. The IO naive patients, similarly, a nice response rate of 30%. In the IO failure, less efficacy. We expect that Cetuximab would have a response rate of about 14% in that setting, and the response rate with the addition of anti-PD-1 was 17%. So at least in the IO naive patient population, an impressive response rate. As we think about, PD-L1 low expressors versus higher expressors, there was this exploratory subgroup analysis by Dr. Sacco. No significant difference by PD-L1 expression, but underpowered certainly for statistical comparison. Maybe a suggestion that lower, this is the 1 through 19, this is less than 1. Lower PD-L1 expressors may benefit from this combination, but more information is needed. And there are other agents that are working their way in, targeting EGFR. This is a compound that's an EGR TGF beta fusion protein, BCA101, that was presented at ASCO this year. This is phase 1 in combination with Pembro, with some stable disease and PRs with an expansion cohort that's ongoing. So targeting EGFR with monoclonal antibody IgG1, showing promise with the combination of anti-PD-1. Another combination using targeted therapy with Cetuximab is that of Monalizumab. And Monalizumab is an NKG2A antagonist, inducing NK cells and CD8 T cells. And this is in a highly refractory patient population, a single arm expansion off of a phase 1. And here, a good response rate of 20%, including some durability in a highly refractory IO failure setting patient population, which has led currently to a phase 3 trial in the IO failure, platinum failure setting with cetuximab plus monalizumab or placebo. So going for registrational status with this combination. So to highlight some exciting data from your own Dr. Saba, at ASCO this past year, a week and a half ago, he presented his trial with Pembrolizumab plus Cabozantinib, Cabozantinib being a TKI, which includes VEGFR blockade. And this trial was for IO naive patients, and they received Cabozantinib plus Pembrolizumab with a really impressive response rate of 54%, impressive median PFS of 14.6 months. You compare that to PFSs of 2 to 3 months for platinum failure IO alone, and around 5 to 6 months in that frontline setting from 048. And similarly, a very impressive median overall survival of 22 months. And my enthusiasm is not just because Dr. Saba is on the line here. It's an impressive outcome, and you wouldn't expect efficacy with Cabo alone. There's no role for these TKIs in head and neck cancer treatment. And I think what's interesting also is the subgroup analysis here. It's exploratory, but nonetheless, look at the CPS greater than equal to 20 patients, where there you can see the median overall survival was a whopping 32 months, which is pretty amazing. And in the less than 20 crowd, that median overall survival approaches that seen in Keynote 048. So a suggestion that if you're PD-L1 expressor by CPS greater than equal to 20, perhaps this is a great combination to move forward in that patient subset. So as we transition from the ongoing exploration, we have a number of things going on. Combination IO has had some failure in phase 3 setting. There are some other combinations that are making their way through phase 2. I think targeted therapy plus IO is showing some more early promise, including Nabil's study that I just mentioned. At Current, there is a phase 3 trial looking at lenvatinib Pembro plus minus lenvatinib in the frontline setting. Lenvatinib, not exactly the same, but blocks some of the same receptors as Cabozantinib. So the field is excitingly waiting that result when it comes out. Lenvatinib plus Pembro is also being looked at in a phase 3 trial in the IO failure setting. But still, there's a great need for improvement in outcomes in patients. And I think what we've learned is that we may need to select PD-L1 cohorts, be more personalized in order to be able to move the needle. That is, do we say, look, this is a combination where we should target PD-L1 low expressors, or is this a combination where we should power our trials for PD-L1 CPS greater than or equal to 20 patients, ultimately trying to take a more personalized approach to try to move that needle to make gains after 048. So what about predictive biomarkers? So for us in head and neck cancer, similar to other tumor types, PD-L1 expression is our most vetted predictive biomarker, with higher PD-L1 expression predicting for increased efficacy. And for us, we do have good data to show that tumor PD-L1 expression plus tumor infiltrating lymphocyte expression has greater predictive value compared to tumor expression alone. Also, immune gene expression, which I'll highlight, and tumor mutational burden has been shown to be predictive. And then we'll talk about HPV. So we've already talked about the fact that HPV positive patients, generally speaking, are associated with a more infiltrated and inflamed phenotype. So how do they do in actuality with their anti-PD-1? So the curves that I'm showing are from Checkmate 141. That was the platinum failure anti-PD-1 treated patients. And there, this is looking at HPV positive patients, Nivolumab versus investigator's choice, and separately, HPV negative patients, Nivolumab versus investigator's choice. And while the HPV positive patients did a little better, period, which we know they do have a better prognosis somewhat in the recurrent metastatic setting, you can see that the hazard ratio was exactly the same, showing that the magnitude of benefit from immunotherapy compared to investigator's choice chemotherapy in the platinum failure setting was similar. That is, HPV positive patients and HPV negative patients get the same magnitude of benefit with anti-PD-1 as compared to, at that time, what was our standard of care. But that's a little different than if a patient, an HPV positive patient, is sitting in front of me and an HPV negative patient is sitting in front of me, and they ask which one of us is going to have a higher chance of response. And there, the data is a little bit more conflicting, but we also have to consider PD-L1 in the equation. So these are some older sort of original trials before we got to phase 3 trials in the platinum failure setting. But this trial, 058, this was a mix of PD-L1 expressors. And here, the efficacy or the response rate was similar. But when you look at trials where you're balancing for PD-L1, that is, at least everybody's a PD-L1 expressor, you can see that the response rate is a bit higher, which suggests that HPV positive patients may have a higher chance of response, but it's not glaring overall. There was a recent suggestion from 048 that maybe the high PD-L1 expressors, amongst the high PD-L1 expressors, CPS greater than or equal to 20, that maybe the HPV positive patients do a little better with chemo plus as opposed to Pembro monotherapy. But I think the summary or take home when you're talking about HPV positive oropharyngeal cancer and treatment with anti-PD-1 is that both HPV positive and negative benefit, which is a great thing, and HPV positive patients may have higher efficacy, but it's certainly not a drastic difference. And I think that includes what we see in the clinic when we're treating these patients. And that may be because of the overall downregulated immune microenvironment when it comes to recurrent disease, with a lot of our exploration of differences in HPV positive being in the locally advanced setting. Perhaps they are more similar in the recurrent metastatic setting in terms of the tumor microenvironment itself. So what else do we know about biomarkers for these patients? This was a study of about 300 or so patients treated with Pembrolizumab, and they looked at TMB, a immune gene expression score, as well as PD-L1 expression. And both, or I should say TMB, GEP, and PD-L1 were all independently associated with efficacy. What was observed is that GEP kind of correlated with PD-L1, and GEP was a little more predictive amongst HPV positive patients, whereas TMB was a little more predictive amongst HPV negative. And intuitively, that makes a little bit of sense relative to perhaps a more inflamed phenotype in HPV positive patients compared to more reliance on a higher TMB in HPV negative patients to activate the immune system. But I think what's interesting about this study is that they also looked at combination, TMB high, or excuse me, TMB and PD-L1 and TMB and GEP. And when you look at the combination of the best possibility, right, TMB high and PD-L1 high, or GEP high and TMB high, it shows you that even with combination biomarkers, the response rate was still, for all comers, 34%. That is to say, and I think that speaks to the complexity of the immune system. But notably, the negative predictive value was about 95%, if you were TMB low, PD-L1 low, or TMB low, GEP low. And that negative predictive value, I think, is increasingly important as we hopefully garner more combinations to use in standard of care practice. That is, knowing that patient is unlikely to benefit at least from anti-PD-1 monotherapy can help us in our discussion about clinical trials and also in selection of standard of care agents. Right now, our only standard of care choice being chemo plus Pembrolizumab, but especially as we gain, or hopefully gain, multiple combinations that we can use at least in the front line setting. So I'll transition now to talking a little bit about some work we're doing here at Hillman. The recurrent metastatic patient population is a passion for mine. And one thing we've created is a recurrent metastatic head and neck cancer clinic, a clinic dedicated to these patients, multidisciplinary evaluations, getting patients in within a week, focusing on improving clinical care and also driving the research machine to try to improve outcomes for these patients. We've developed and continue to raise our numbers for a translational research database that is a recurrent metastatic anti-PD-1 treated patients with choroidal blood being drawn pre and on treatment for standard of care patients. And of course, trying to drive clinical trial development to help improve outcomes in these patients. So I'll highlight a little bit of work that we've been doing. Greg Dalgoff, one of our PhD immunologists here, his big focus is in metabolism, and so he, in a mouse model in head and neck cancer, had observed that as that head and neck cancer, that squamous cell carcinoma, gets anti-PD-1 resistant, there's an increase in oxidative phosphorylation, driving a reduction in hypoxia, subsequent reduction in CD8 T cells, and also decreased function of those CD8 T cells. And so with that, we combined and looked at in patients, what is the effect of hypoxia? And that was by using carbonic anhydrase 9 for staining. And we found that there was a significant improvement in disease control and also in PFS and OS if you had lower hypoxia. That is, higher hypoxia is worse. Lower hypoxia, there was significant improvement in efficacy with anti-PD-1 treatment in the recurrent metastatic setting. And this is a retrospective study. There was also significant improvement, as expected, if you had higher CD8s. And we looked, and both in the multivariate analysis were independent of each other, which is important. In this particular study, we didn't look at the function of those CD8s to see whether or not there was impairment in function. But interesting nonetheless, when we looked at categories by OS and PFS, you could see that by OS, hypoxia low, CD8 high really sticks out, whereas the other categories kind of meld together. And I think that relates also to the question of do patients with, for example, high hypoxia but high CD8s potentially have exhausted CD8s driven by that hypoxia. We took it a step further and we looked at radiomics as predictive and good sensitivity and specificity for looking at pre-CT scans by radiomics for predicting both hypoxia and also disease control rate. And this is something that the manuscript is in development for. Dr. Dalgoff had previously looked at, are there any agents that can modify hypoxia? Of course, that is the bigger question. It's exciting, certainly, to have a predictive biomarker that might be able to be intervened on. The challenge is how do we actually reduce intratumoral hypoxia? And he's done a lot of work with metformin in a mirror head and neck model, showing that metformin works preferentially on tumor cells to reduce OXPHOS and thus raise hypoxia with synergy with anti-PD-1. And also at rosiglitazone, similarly, can inhibit OXPHOS in the T cells and improve T cell mitochondrial mass and metabolic function. And so with that backdrop, we developed a trial looking at patients with anti-PD-1 naive recurrent metastatic head and neck cancer. That can be frontline or platinum failure, whenever an anti-PD-1 is indicated, for standard of care, and randomizing them to anti-PD-1 alone, anti-PD-1 plus metformin, and anti-PD-1 plus rosiglitazone. Subsequently, rosiglitazone, the company that makes rosiglitazone from diabetes, stopped making it. So now it's just randomized metformin or anti-PD-1, looking at clinical comparison, but also pre-treatment and on-treatment biopsies to determine whether the mechanism of action is what is observed in patients as it is in the lab, towards the goal of trying to make things more personalized for our patients. This is a trial that I also developed looking at anti-PD-1 failure patients in the recurrent metastatic setting. These patients get a pre-treatment biopsy by immune gene expression, and we're using immune gene expression to select patients that will receive Nivolumab plus. In this case, we have two drugs at current to use, either relatlimab or ipilimumab, based on CTLA-4 or LAG-3 expression difference. If the difference is big enough, and I won't bore you with that stats analysis as to the number we set, then you select, or if not, you randomize. We estimated that about 30% would be selected. We have about 14 patients on, and that percentage is kind of holding true. So this is a first step towards taking a more personalized approach. This is kind of a apparatus, if you will, for adding more drugs as we can get them, to make it a more personalized approach. And our goal is to leverage these trials to look at anti-PD-1 naive patients in the metabolic modulation trial, and that fresh biopsy before treatment in the anti-PD-1 failure trial, ultimately to look at what happens as you get exposed to anti-PD-1, including specifically from a metabolic perspective, in line with Dr. Delgoff's primary focus. So lastly, or as we kind of transition to the end here, I'll highlight some other recent work that was presented at ASCO a week and a half ago. I worked with Nicole Sheff. Dr. Nicole Sheff is a PhD scientist whose big interest is in pain and what happens biologically with pain. And we know that opiates can have an immunomodulatory effect. A lot of that data is in non-cancerous situations, for example, perioperative opioids relative to wound healing, with some data also in cancer, showing, for example, that the mu-opioid receptor, or some of our data has shown that the mu-opioid receptor is expressed more in immune cells in the tumor microenvironment than in the peripheral blood in cancer patients. And so we looked in our retrospective anti-PD-1 treated database to see those patients that are on higher opioids pre-treatment, looking at a pre-treatment visit and then the day of IO, and whether that correlated with efficacy. And we found that there was a significant correlation with increased opioids before anti-PD-1 in terms of PFS and OS. That is, higher opioids were associated with a lower PFS and OS, also independently so for these parameters. No correlation with disease control rate. And then we looked also in the tumor microenvironment to see whether there was at least a biologic difference by opioids. And what this is showing is that if you had higher opioids, if you were on opioids compared to those that were not, you had significantly lower CD8 and a lower CD8 Treg ratio compared to those that were not on opiates, suggesting that opiates may cause reduction in these cells. Now, this is hypothesis generating, of course, not hypothesis confirming, but interestingly, nonetheless, relative to a common, obviously something we have to use, but what could be its immunomodulatory effect? And in addition to us developing the manuscript here, Nicole is really going to try to work on pinning down what could be the exact biologic mechanism for immunomodulation. And switching gears kind of lastly, the other question that comes up with our success with anti-PD-1 in the most advanced setting is, can we use it earlier on in the recurrent metastatic setting? Really our biggest rescue factor is with salvage resection. However, outcomes still, there's a great need for improvement. You can see somewhere around a 30% 5-year survival after salvage. And a lot of patients do worse than that, depending on how quick their disease-free interval is and other prognostic markers. So based on anti-PD-1 having a defined role against microscopic disease in melanoma and preliminary data in head and neck, as Dr. Saba highlighted, I developed in study chair and in collaboration with Mihir Patel, I developed this trial, which is EA3191, which is looking at patients that undergo salvage resection for recurrent or second primary head and neck cancer that have high-risk pathologic features, and then are randomized to reirradiation with Pembrolizumab, reirradiation with weekly platinum, or Pembrolizumab monotherapy. In our field, we can do adjuvant reirradiation. However, it didn't improve overall survival, only disease-free survival in a prior randomized trial, and it's very toxic. So it creates the clinical equipoise to challenge it, and I think most provocatively with Pembrolizumab monotherapy, and the primary endpoint is overall survival. Each experimental arm is being compared to control separately, and we're enriching for those that would benefit with immunotherapy by including only PD-L1 expressors by CPS. So in conclusion, we have made great gains in the recurrent metastatic setting. Anti-PD-1 monoclonal antibody-based therapy is now our standard of care in the frontline setting, and also if you still meet the definition for platinum failure. Of course, there's still a need for an improvement, both in IO naive and especially IO failure. Targeted therapy plus IO showing some promise and moving in, or some ongoing phase 3 approaches. And of course, we have to get more personalized both in terms of, as I mentioned, looking at what we know now in terms of PD-L1 expression. But in my humble opinion, while I hope, of course, that there's a combination that works in 90% of patients, I think more realistically, you're going to have to select patients for individual combinations in order to get the majority of patients to benefit from immunotherapy. And, I think we need to take steps as a field where clinical equipoise allows to select based on biomarkers prospectively to try to really move the field forward. But to end on an even more optimistic note, like I said, great gains in the recurrent metastatic setting, a lot of studies ongoing. About 10 years ago, the only thing you could find for a recurrent metastatic patient was a phase 1. So really wonderful, exciting times in head and neck, and also more importantly, wonderful for our patients in terms of options. So with that, thank you very much for allowing me to speak today, and I'll stop and answer any questions.
I want to thank Dr. Zandberg for a great talk. Thank you, Dan. This was really thought-provoking. This was really a great tour de force with looking at biomarkers, looking at the landscape in recurrent metastatic disease. And I hope that will generate a few questions from the audience. To the attendees, if you have any questions, I would urge you to use the Q&A feature located at the bottom of your screen. And while we're waiting for questions, a couple of items I wanted to mention for the attendees that next week we will hear from John Carpton from the University of South Carolina, who will be presenting the impact of heterogeneity in cancer genome science. And I remind you as well that if you want to view all the upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. Dan, while we're waiting for questions here, very thought-provoking discussion. I was very interested in your trial of reliclimab and Nivo versus the ipilimumab and Nivo. Given that this LAG3 expression is high, how are you selecting, and the way I understood it is it's not really randomized. You're selecting based on biomarkers. Right. If you can detail some of the processes you use on how to select in which arm they go, because, the CTLA-4 probably is a non, you don't need to select a lot, but I think for the LAG3 specifically.
Right. So, what we're using is immune gene expression via OmniSeq. OmniSeq has a CLIA certified assay and can run it quickly. And they have an immune report card that they use, for their bulk RNA-seq methods. And they have about 52 and growing immune genes that they profile. So what we do is every patient gets a fresh biopsy, and they use FFPE for the analysis. And we check immune gene expression. To your point, there's nothing perfect for ipilimumab. At Current, my hope was, of course, that we can have more drugs. At Current, those are the drugs that were made available for the trial. And what we're doing is we're looking at expression of LAG3 and CTLA-4. If there's a difference, and we calculated based on some statistical consideration, a 15-point difference. If there is a higher than 15-point difference, we select the agent that's higher. So LAG3 is 15 points higher than CTLA-4. Then we select relatlimab to add to nivolumab, and we treat with Nivo plus Rela. If the difference is less, then they're randomized to one or the other. So with clinical equipoise allowing these treatments, we are looking in an exploratory fashion as to whether selecting is better than just randomizing to one of the two combinations. And again, the hope is that we'll have more drugs to enter in there as the trial evolves. Like I said, kind of a platform also for adding other drugs to make the selection more personalized itself. So a first step towards that prospective use of immune gene expression to be able to select combinations for patients based on their tumor microenvironment.
So we have a couple of questions. I'll start from the audience by Dr. Shin's question. I'm going to read it. Basically, Dan, great talk. Now we know IO-TKI, Pembro from Cabo is a potential winning if we do randomized trials. Further, IO-EGFR has also had good activity. What about, do you think we can combine 3 different pathway agents? such as IO, TKI, like Lenvima or Cabo, and EGFR. Side effects may be entirely overlapped. What do you think? Are we ready for a triplet?
No, I think it's a great question. I mean, I think that, the mechanisms actions, the question is whether they're separate relative to, immune modulation or stimulation. And then you get into the toxicity question. Certainly the TKIs, can come with toxicity. EGFR is generally well tolerated. But I think it's an interesting question. I think certainly the doublets, are moving forward. But I think it's an interesting question to test if you could.
Yeah, and I agree with that as well. I think those, the future will hold a lot to try to answer with different combinations along those lines. Let's read a couple of questions here. There's a question saying, any reason why Ipi-Nivo versus Ipo-Relatlimab instead of comparison, I think the way I understand the question, to single agent Nivo. To my understanding, this is an exploratory trial, but you can elaborate on that if you like.
Right. The goal of the trial is to look at the efficacy with selection versus randomization to one of the two combinations. So while the schema, does show what looks like a randomization, there is no powering against each other. And because it is anti-PD-1 failure, we can't look at the anti-PD-1 alone subsequent re-challenge. So it's a good question. I think the schema as I have it is a little bit, makes it a little bit more confusing, but it's selection versus randomization to the two combinations and looking at the efficacy comparatively.
Right. Yeah, I think in that patient population, I absolutely agree. You need to move to. There is some data from 141 on continuing Nivo post-progression, but this is very meager responses. And, I don't think people would agree that this should be a comparator or standard comparator arm. Let's see, a question from Dr. Al-Usta. Great talk. What is the role of upfront taxanes with IO in the first-line recurrent metastatic? That's very interesting, I think.
Yeah, that's a great question. Yeah. So, in 048, it was platinum 5-FU Pembro. At Current, Merck has a trial that's a phase 4 single-arm trial using Carbo-Taxol Pembro, just to drive or see what the efficacy is. In head and neck cancer, we know from a phase 3 trial done, a couple of decades ago, that platinum taxane is equivalent to 5-FU in terms of efficacy. So the question is taxane with anti-PD-1, either with platinum or by itself, better than 5-FU? I think when you look at the data, I think there's more data for immunogenicity, perhaps with taxane compared to 5-FU. So as a result of that, and as a result of the backbones being equivalent, actually Carbo-Taxol Pembro is a NCCN Category 2 indication. And I think some folks reach for Carbo-Taxol Pembro already as a frontline setting, as a frontline choice. So we'll see how the data looks. I mean, my impression is that, I'm sure it's going to be equivalent, maybe better, to platinum 5-FU Pembro. Nobody likes to use 5-FU. It's 4 days worth, so it's tough to tolerate, but we'll see how the data looks. So it can be it can be used, Carbo-Taxol Pembro, it is being used. I do use it sometimes. Sometimes I will use platinum 5-FU if I have a patient that I think is going to be heading to trial down the line, just because we have a paclitaxel plus minus buparlisib trial. So I kind of look at what trials I might be having. And I also sometimes will use platinum 5-FU Pembro as frontline therapy because taxane is a little bit better standalone agent down the line to kind of save my taxane for later. But no right or wrong answer there. It's a little bit of dealer's choice as we await the phase 4 data for Carbo-Taxol Pembro.
Right, I agree. And I think the question of sequencing with taxanes is fascinating. I know,
yep.
You know, Dan, we've talked about this a number of times. And I think the GIGE data from Europe really is suggestive, even though, subset analysis of, subsequent use of taxanes versus non-taxanes. So this is the last of the audience question. If I could squeeze in another question, I would say, what are you guys doing with your CPS less than 20? Less than 1. Less than 20 is easier. But for your, even, this is a small group of patients, as you indicated, Dan, and so very unlikely to happen. But what's your go-to regimen?
Yeah, I mean, for CPS less than 1, standard of care, I'm using chemo plus. And trials wise, you know, we do have one trial with IO combination that's looking at less than or equal to 1, or has an exploratory cohort. But it's a need. I mean, even the exploratory analysis with chemo plus Pembro for CPS greater than or equal to 1, right? It's exploratory. It's low numbers. It's only 15%, but it didn't look that good compared to extreme. So standard of care, I'm using chemo plus Pembro, but I think it's a need, you know, definitely. And you know, the challenge, of course, is just because it's a lower percentage of patients, hard to study in isolation itself. You know.
Great. I want to thank you again, Dan, for a very thought-provoking talk. Since we don't have additional questions, we basically will close the meeting a little early, but it was really very thought-provoking, and we hope to see you in person, hopefully in the near future.
Great. Thank you very much, everybody.
Thank you, everyone.